Thank you very much. I first want to give my great thanks to Andrea Tenazzani, who allows us in this environment to talk about many problems which exist in Europe regarded to reproductive health questions. I have to talk about what can European societies contribute, but I will once again, like Johannes, give you some data on the background, because the question is really what is the situation before we talk about the things we can do, the actions we take. And I want to thank my friends, Dr. Rudolf Kirschner and Dr. Mohamed Tahir from EPCOG, who allowed me to use some of their slides, which she presented at the last ESC Congress in Budapest. I will talk about the situation in Europe and discuss with you which are special critical areas. I will inform you about the recent activities of ESC and EPCOG and plans and ideas for the futures, and also the hurdles we have to face on the way to improvement of reproductive health for all women in Europe. Now, what is the situation? Globally, 885 million women of reproductive age in developing regions want to avoid a pregnancy, and 214 million of them have an unmet need for modern contraception. We will talk about what that is, an unmet need. And if you look at this slide, you see the percentage of pregnancies which are aborted by regions, and that visible here, the red areas are regions with very high rate of abortions in comparison to pregnancies which occurs. And if you look at Europe, you see that Eastern European, especially former Soviet Union countries, are much more affected than other countries in Europe. Now, contraceptive use has made some steps from 1990 to 2012, but not so many. Especially if you look at our region of interest, Caucasus region and Central Asia, you see that the contraceptive prevalence has increased only from 49 to 56% over more than 20 years, and the unmet need have not decreased a lot. Now, why do we talk about unmet needs? Usually on the slide you would only see how many women use a contraceptive, but we want to know how many women would like to have no child, to plan their child, to use a contraceptive, but are not able or have no access to a method. And therefore it's important to also define the unmet need. It's an indicator for the gap between demand and use. Now, women with unmet need for modern contraception methods account for 84% of unintended pregnancies. What can European societies contribute? 240 million women of reproductive age in developing countries who want to avoid pregnancies are not using a modern contraceptive methods. And why is that? Limited choice of methods, as Johannes said, limited access, fear of side effects, cultural or religious opposition, poor quality of services, users and providers bias, misconceptions, specialists are not educated, and gender-based barriers. So some men might not allow their women to use a contraceptive. Again, on which level can European societies contribute to improvement? And I agree a lot with Johannes that, for example, on an educational level, we could face a lot of all these green points to reduce fear of side effects, to improve quality of services, to also face cultural beliefs, because if women understand more what is happening in their bodies and what the methods are doing with their body, they might easier agree to use a contraceptive. And of course, we have to remove all these myths and misconceptions. We also have to improve teaching in the local languages. And we have to teach how to remove this myth and misbelief. For example, what my idea is, if a woman, and I must say, when I had a course in Moldavia with many opinion leaders from countries around, I realized how huge these myths and misbeliefs are. And if you tell a woman, we have all this medical eligibility criteria from WHO, they are very good spread, but you can't tell a woman if she is afraid of future fertility or breast cancer when she uses a pill, you are WHO1, please use it. You need arguments. You must tell her the breast cancer rate is that and that high. The fertility of women with, after so many years using a pill is in certain numbers. So this is the way I think we come further to remove myths and misbeliefs if we substitute them by facts. And of course, we have worked together with WHO and UNFPA, and we have provided arguments for Department of Health that they see that they are much finer, that they save a lot of costs if they, for example, reimburse all contraceptive methods or a broader range. Now, this is a slide showing the unmet needs for contraception in Eastern European countries, most in the former Soviet Union, and you do not only see the percentage of women with unmet needs, which ranges from 10 to 20%, but also the percentage of use of traditional methods and then of modern contraception. And I'm wondering, think about what would you understand under the word modern contraception, because I think for many people there is a huge misunderstanding, and this slide looked much better than the situation is. Does modern use of modern methods mean efficient method? And what is a traditional method? And is a rate of 10 to 15% of unmet needs worrisome? Now, in all the definitions, including the contraceptive methods, modern contraception does not mean at all efficient contraception or inhibition of ovulation, because it includes male and female condom use, it includes vaginal barrier methods, and it includes emergency contraception, what we in Western European countries would not accept as an efficient protection against pregnancy. The traditional methods are also still widespread, rhythm withdrawal, though that might mean that these people do not have education and knowledge about more and other modern contraceptive methods. Now, many couples use, according to the graph, modern methods, but they might not be highly efficient, and we don't know how many condom users these are. 20 to 60% in these countries use traditional methods like withdrawal with low efficiency, and 10 to 15% do not use any methods, although they would like to have contraception. Though I think these numbers are actually all very worrisome, and we need better definitions. The most effective countries with the highest unmet needs are here on this list, many of them only with also educated people understand only Russian language. And what also was investigated by WHO is that in the difficult regions, for example, a better economic situation is associated with a higher probability to use efficient contraceptive methods, and if you, for example, have a better economic situation and a better education. Key factors, what were the key factors for low contraceptive use? That was one, lack of government commitment, and I think we have to collaborate with the departments of reproductive health in all these countries. There is huge misinformation, myths, and distrust towards modern hormonal contraceptive, and here I mean efficient hormonal contraceptive, and providers lack skills. They do not always provide updated and correct information. In contrast, they further spread the myths which are in this region available. Counseling altogether is rare. You might receive a prescription, and the availability of methods can be low. So I think, especially with regard to the government commitment and reimbursement and access and opening up of new reproductive health centers, we need close collaboration with WHO and UNFPA, because they can act better on political levels. You see that in all these countries, in addition, teenager pregnancy rates are very high, and they are also the top countries for less effective contraceptive use. Now, I am coming direct to the results of the contraceptive atlas, and I'm not so happy with it as well, because they look at 4 points, but in the end, this might not reflect the final situation. For example, you see these countries which are rated as excellent, and then we have the countries which are rated as very poor in the contraceptive atlas, and I agree that most of these countries rated as very poor or poor are indeed in a not so good situation. But for example, if you look at the medium countries, you have Denmark, Finland, Italy, Switzerland, and I think this is not true. Also, Ukraine might rather come to the right side, but this is always, if you look at only 4 facts, reimbursement availability, you might only, that does not reflect the situation overall, and I think here the methodology really should be improved. I already said, in many countries with the highest needs, language is a high hurdle. Now, during my time as the president of ESC, I collaborated with WHO. We thought about what we could do for these countries and developed a teaching and trainers course with the idea that we teach people who are very engaged for contraceptive and reproductive health in these countries. Visit a 2-day course, learning a lot about all contraceptive methods, and then go back and use this material to teach in their country, to go to congresses, to organize events. And another thing, what I think now I hope is on a way that we are close to the end, Johannes, is the EPCOG activity to develop a master for sexual and reproductive health, because that means that people who are guiding a Center for Reproductive Health can make an examen which is everywhere acknowledged. This might also be UNFPA reproductive health centers, government-opened reproductive health centers, and it contributes a lot to the quality of services if we have such an option. Again, the question is how to teach opinion leaders in the region, how to remove misbeliefs, how can we teach knowledge in a way that providers can use their brain more than guidelines? Because in certain countries, it's always, people were always told what they have to do, and they really rely on this sort of guidelines. But to counsel a patient, you need a bit more of knowledge, and especially to remove the myths. So the concept of the European Society for Contraception and Reproductive Health teaching tool is to substitute myths by facts, enable counselor to answer critical questions and concerns with regard to facts. For example, telling the woman, you don't have to be worried about depression. It's only this and this number of persons who might develop a depression in such a case, in case of human using hormones. Another thing is that, of course, we should teach those people who are really engaged in their countries and who will continue with activities. And the courses are developed on a 2-day basis, because more days would be lovely. 2 days are very intense, but once for 3 or 4 days you need more money, and people have to leave their work and come there. So we thought that is the most efficient way that we can realize something. We have to prepare the material in a way that they can use it for teaching in their countries. And again, the counselor should be able to answer critical questions and concerns and present used evidence-based scientific knowledge. The teacher course includes 16 sessions and 4 workshops. First one was held together with WHO in Belgrade, and second one was again in Belgrade, because we found out that we have Katarina's Athletics there, who is organizing a lot at this place already. So this is very easy. And I must say, for the second course, I had an ESC budget of 4,000 euro, and we could make it in Belgrade. We could organize this course with 5-6 people in Belgrade. I think that would not be possible without having somebody at this place who makes the work, and also hotel costs and everything is much lower, which is important for people who come from low-income countries. We have all these advanced sessions on combined, progestin-only pills, IUDs, medical condition sessions, and all this has to combine in a case workshops and a final Kahoot test. And when we say in a test special things have been frequently answered in a wrong way, we improve the slide for the next course and also change our presentation to make this more understandable. The workshops are really very difficult. We, the teachers, mostly are the patients. We ask very difficult questions to the providers, but after the course, they should be able to answer these questions. And we only added additional knowledge. It's an advanced course. We didn't want to repeat that, what already is available from FSRH or WHO. Yes, I think altogether this included 400 slides. And as I said, the last course was really cheap, though I hope we can continue with future courses. In the course, we had participants from Kazakhstan, Moldova, and Russia. The participants were very good with English knowledge, but they said, we cannot use these slides in our countries. We need a Russian translation. Doctors don't understand this. University professors also might not understand this. And so all these sessions were translated into Russian language, and here we had a lot of help from Gideon Richter, and they also supported some participants to come to the second course. Without them, this would not have been possible, and I'm really very grateful to this, and also to our ESC board members who continue with updating Russian slides or checking the contents of the translation. So as a consequence of this, teaching the teaching tool and courses, meanwhile, 7 courses have been performed from earlier participants in their countries. 9 countries have adapted or updated their guidelines, or for the first time made some guidelines. So I think this is a very good result for 2 courses. I am spreading this. Now I want to come to the EPCOG activities, which I think are really very important to improve the quality of services. And first you have to define what is the standard of care. With regard to obstetrics and gynecologists, many steps have already been made by EPCOG, and also with defining the standards of care in different areas. But there are still more goals to be done, like a European diploma, for example. And we want to collaborate with developing bachelor and master title in sexual and reproductive health, as Johannes already said. And I think he is working on this idea for many, many years. I'm so grateful for this ambition and his endless work, continuation, also it is not so easy to bring all the people together. Johannes already presented what should be the contents of this master on different steps. And in the end, there will be 3 levels of an examen, but I think in every reproductive health center there should be at least one person who has this final master. Yeah, now what is needed? For the ESC courses, we have limited resources. I think it is important to identify providers with a teaching role from countries with the highest unmet needs to provide these services, because we cannot teach 300 people per year. We have to organize money to invite people from the low-income countries. We need skilled experts to keep this teaching tool available and updated and available with all the new scientific knowledges coming out. And of course, we need collaboration with WHO and UNFPA and EPCOG to bundle the at present for all these societies low resources. We need dedicated experts willing to work on the content and the masters in their leisure time, in their free time, and unpaid. Now, the question is, what do other European societies, like the Society for Obstetrics and Gynecologists or the Society for Gynecologic Endocrinology, can contribute? I think they also can contribute. For example, with specialists who are working on these tools. They can also, for example, add a part of this Teaching the Teacher course to their congress, for example, a one-day part, though that people who are already at a congress on a very low level can just stay and have fun overnight more and use this option to get a lot of knowledge. And they could perhaps sponsor potential participants of the master course or of an ESC TTT course. I think we have to do that together. If not, we will not be able to move forward in times where reproductive health is not considered as the main goal from many politicians.